Good morning. Can you hear me?
Yes,
People? Good morning to you. Hello there.
We can hear you, sir.
Hello, we are going to start. Hello, we are going to start. Good morning to you, all of you. Hello.
Good morning, sir. We can hear.
Good morning. Can you hear me? Fine.
Yes, sir, we can.
Excellent. Very good. Okay. So, right. So today a bit less number of participants. Okay, but I usually start on time. So today what we are going to do, we are going to discuss two topics, right? We're going to start talking about Gallstone disease, and we're going to talk about acute pancreatitis. So there's a reason why we are going to talk about two topics, because this lecture is we are conducting online, and therefore I won't be able to ask a lot of questions. My usual pattern of teaching is I do a lecture and it's a very interactive lecture. So I put the slide and I ask a lot of questions from the audience. So that takes time. But here, when you are doing on a distant method, there's minimal interaction. So therefore, I think I'll be able to finish one topic fairly early. Therefore, I thought I will include two topics, right? And right. So have you all seen patients with Gallstone disease? Very common in the emergency setting of general surgery, and also in the elective setting. A lot of patients come with Gallstone related problems, and we manage them symptomatically. Some of them undergo surgery. So I'm sure, have you all seen a lot of patients with Gallstone disease, biliary colic, cholecystitis? Yes. Right. Okay. So what is gallstone disease? Gallstone disease is stone formation in the gallbladder. So you must try and remember your gallbladder anatomy. So you have your liver, and the two hepatic ducts come and join the common hepatic duct, and then common hepatic duct is joined by the cystic duct and forms the common bile duct. And then common bile duct that goes and opens into the second part of the duodenum. So that's roughly the biliary anatomy. So this is a very important area, because you must have learned in anatomy that there are so many variations in gallbladder or the gall in the biliary anatomy that can happen in normal people. So these variations are very important, because when you will learn in a minute, when you start doing operations in this area, the familiarization with the anatomy, the variations and abnormalities in the anatomy of the biliary system is very important. Because if you don't know that, if you don't appreciate those abnormalities, you will end up in disaster at the time of operation. So we'll just touch on that a little bit later. So gallstone disease is stone formation in the gallbladder. We are mainly talking about gallstone formation in the gallbladder. So we know about roughly about 3 types of gallstones. So the etiology, the most common one is the mixed stones. 80% of the gallstones are mixed stones, and they contain cholesterol, calcium, bilirubinate, phosphate, and proteins. So these mixed stones usually occur in older people, especially in females and obese people, and people on oral contraceptive pills, and in people who had a family history of past history of terminal ileal resection. The second type of gallstones that we are going to talk about is about pure cholesterol stones, about 10% of all the gallstones. So it's again occurs in similar association with mixed stones. Third one is pigment stones. Roughly again, about 10% of gallstones are pigment stones. So they are black horns. It should be black stones made of calcium bilirubinate. So these pigment stones, occur in people with hemolytic disorders, for example, sickle cell disease, and in patients with cirrhosis. Let's move on to the next one. Yeah. That looks fine. Yeah. So what is the epidemiology? So it's a very common problem, as I told you, not only in other parts of the world, in Sri Lanka also, gallstone disease is very common. It's very common in the emergency as well, in the emergency and elective setup. So it's very common in developed countries because they have a lot of protein usage in their meals. So UK prevalence is about 10% more common with age. It's about 10 times more in females of more than 65 years old. So usually the prevalence increase with time, but equal sex ratio after 65 years. So usually roughly about 50,000 cholecystectomies done in UK per annum. So you have a good homework that you can do. You can find out how many cholecystectomies are carried out in Sri Lanka, roughly in Karapedi Hospital. You can find it out, right, as a homework, right? So what's the history of a patient who has got, who will be coming to you when you are an intern in the emergency ward, or maybe you are working as a MO in a clinic. So most of the patients with gallstone disease are asymptomatic. Most of the patients with gallstone disease are asymptomatic. So about 90% are asymptomatic. So they will come with some abdominal pain or any features of GORD, very mild abdominal pain, and the doctor will arrange ultrasound scan, and you will find there is an incidental finding of gallstone. So most of them are asymptomatic. Then others will present with biliary colic, pain in the right hypochondria, right? So sudden onset, severe right hypochondrial pain, or sometimes it can be in the epigastrium. Constant pain, it can radiate to right scapula, and usually this biliary colic pain is precipitated by a heavy fatty meal, right? So then another set of patients will present with acute cholangitis. So what is that? When cholangitis happens, patients are systemically unwell. They have high fever, right hypochondrial pain, shoulder tip pain. There's diaphragmatic irritation, and uh, some of them have jaundice. So here, there's another presentation. It is acute cholecystitis. Acute cholecystitis is patients presenting with right hypochondrial pain, fever. There's tenderness in the right hypochondrium. On examination, there's positive Murphy's sign, and Boas sign will be positive. So they are coming with acute cholecystitis. So there's this thing called ascending cholangitis. Ascending cholangitis is there is an important triad that you will remember. It's called Charcot's triad. That is right hypochondrial pain, and patient is having jaundice as well as rigors, right? And if combined with low blood pressure, they are very systemically unwell, and if they are hypotensive and there are confusion, you call it Reynolds pentad, right? So here you are. At this point, I think it's important to know what is the pathophysiology, how does the biliary colic happens, and how does the cholecystitis happen. Can anyone think about? Biliary colic is when the stones in the gallbladder comes into the Hartmann's pouch and gets obstructed. So when the Hartmann's pouch is obstructed, there is obstruction of the cystic duct, so the bile cannot flow into the common bile duct. So the patient develops biliary colic. So after some time, this stone falls back into the gallbladder, so the biliary flow is established, so the pain is disappeared. So this is biliary colic. But what happens in cholecystitis? In cholecystitis, what happens is this stone, which is lodged in the Hartmann's pouch, doesn't fall back to the gallbladder. So there is accumulation of bile, there's fluid exudation, there's continuous pain, and there's infection sets in. That's cholecystitis. So you can see the differences between the biliary colic and cholecystitis. So let's see, the onset in biliary colic is rapid onset, in cholecystitis is gradual. The nature in biliary colic, it's a colicky pain because the stone goes and lodges in the Hartmann's pouch, but after some time it comes back, it falls back into the gallbladder. So the pain is relieved. So it's a colic, intermittent pain. But in cholecystitis, it's a constant pain. Pyrexia, there's no fever in biliary colic. You will understand that because there's no infection setting in, no inflammation, because the stone quickly falls back. But in cholecystitis, the stone is there, it's stuck in the Hartmann pouch, so there is infection setting in, there's fever, right? So what about peritonealism on examination? There's tenderness, usually very minimal tenderness or absent tenderness in the right hypochondrium in biliary colic, but you will, when you see patients, when you examine their abdomen, you might see a little bit of tenderness, but usually it's very minimal or it's absent. But in cholecystitis, they are having severe tenderness in the right hypochondria. So much so they will have positive Murphy's sign. Does everyone know what's positive Murphy's sign? If you don't know, better know that, because if you come, when you come to do the appointment in the final year, I'm going to ask you. Right. So there you are. You have the Murphy's sign. Next, Murphy's sign positivity is very weak in biliary colic, but it's very much positive in the cholecystitis. Right. So can there be a mass in the biliary colic? Can there be a mass in the right hypochondria? Very most of the time no mass, because there is no time to form a mass, because the stone quickly falls back into the gallbladder, so therefore there's no mass formation. But what about cholecystitis? In cholecystitis, yes, you can have a mass because the stone goes and lodges, there is accumulation of fluid, there is exudation, there is initially there is mucocele formation inside the gallbladder, and with the infection this mucocele can convert to a empyema of the gallbladder. So therefore, when you examine the right hypochondrium, sometimes you might feel a mass in the right hypochondrium. So as an intern, if you examine, when you examine this patient, very important to tell me that whether there is a mass formation or not in the right hypochondrium, right? What about the white cell count in biliary colic? What about the white cell count? No infection, no minimal inflammation, white cell count is normal. So in cholecystitis, it's elevated, right? So like that, okay. Um, Gallbladder on ultrasound. So in biliary colic, usually it's thin wall. So no inflammation, no repeated inflammation, though there's no chronic inflammation happen there. So therefore, in biliary colic, the gallbladder on ultrasound scan has a thin wall. What about cholecystitis? Most of these patients, if you don't operate them with cholecystitis after their first episode, they will come with recurrent episodes of cholecystitis. So there's chronic inflammation. So on ultrasound scan, they will be having thick wall gallbladder, thick wall. And if you are doing the scan in acute setting, you will see a pericholecystic fluid around the gallbladder. It's called pericholecystic halo. Better know what is a halo, right? So that's about the differences between biliary colic and cholecystitis, right? Okay, so so you get patients like that, and you take the history, a detailed history into their presentation, their past medical history, surgical history, medical drug history, allergic history, and all that. Then you will have to examine. So, what about examination findings in biliary colic? There is right hypochondrial or epigastric tenderness, very minimal, as I told you in the previous slide. What about acute cholecystitis? You should be able to tell me now. So they are tachycardic, their pulse rates are high because there's infection, inflammation happening, and some of them are pyrexial, there's right hypochondrial tenderness, and there may be guarding, there may be rebound tenderness, and most of them will have a positive Murphy's sign. What is the examination finding in ascending cholangitis? In cholangitis, you will get fever, jaundice, and right hypochondrial tenderness. Right. So this is what I have already explained to you, the pathology or the pathogenesis of biliary colic and related complications around the gallbladder. So biliary colic, you should be able to tell me now, impaction of gallstone in the Hartmann pouch. So it goes from the gallbladder, the stone moves out of the gallbladder through the opening into the Hartmann's pouch. You should know where the Hartmann pouch is. And it stucks in the Hartmann's pouch, but after some time, it spontaneously falls back into the gallbladder. So the pain is relieved. So therefore, when the obstruction is relieved, the pain is relieved. So there's impaction in the Hartmann pouch and resolves when the stone falls back to gallbladder. So cholecystitis, what is it? You should be able to, just figure out what happens. The stone doesn't fall back. It stays there in the Hartmann's pouch. So there's fluid accumulation, all that, and forming a mucocele, empyema of the gallbladder. So there is acute cholecystitis. Right. So if you don't operate, as I told you earlier, following acute cholecystitis, they will go into chronic cholecystitis. So patients will come with repeated episodes of cholecystitis. So when you take the history of these patients, it's important to know which episode is this, how many times the patient has been admitted to the hospital with this problem. So sometimes your history is very horrible, right? We can't work with your history. So important to take a detailed history. That is your duty as a house officer. The first thing, to get a very detailed history. Very important in this case, because you need to know how many times this patient has come to the hospital and was admitted with this problem. So for you to plan your management, right? Okay. So chronic cholecystitis happens following acute cholecystitis if you don't operate. So in chronic cholecystitis, you get shrunken fibrous gallbladder. Because repeated inflammation, chronic inflammation, the gallbladder wall is shrunken and it is fibrous, but it is thick with transmural fibrosis. The wall is thick. That is why when you do a scan, you will see a thick gallbladder wall compared to acute cholecystitis first episode or biliary colic, where you get a thin gallbladder wall. There's dystrophic calcification. You should know this dystrophic calcification in pathology. You must have learned dystrophic calcification. What are other types of calcification? Anybody? Wake up from your sleep.
Metastatic calcification.
Yeah, there are two types of calcification: dystrophic calcification, metastatic calcification. Better refresh your memory. So dystrophic calcification in gallbladder wall results in a thing called porcelain gallbladder. It's very common. It's not that common, but it's very distinctive, very characteristic. When you feel that gallbladder, it's like a Chinese, that porcelain, like your ceramic work, right? So ceramic object like a porcelain gallbladder, like a so it's very tense and it's very thick wall, very shiny, glistening surface, which is called porcelain gallbladder. And you have a condition of porcelain gallbladder, there's a risk of high risk of malignant transformation of that gallbladder, right? So here you are, the problems of gallstones. Try to give you in a diagram. You can see now the gallstones, if they migrate, what can happen? Gallstones, if they go down the common bile duct, they can obstruct the common bile duct. They can obstruct the pancreatic duct. They can obstruct the sphincter of body and cause jaundice and pancreatitis, right? And gallstones causing infection can cause all these three: cholangitis, cholecystitis, and empyema. So somebody will ask you, what is empyema? You should be able to say pus collection of pus inside the gallbladder is called empyema, right? So that is with infection. Gallstones, obstruction of the outlet, and continuous obstruction with no resolvement. There's fluid accumulation and infection causing empyema. The gallbladder is filled with pus. So that's called empyema. If the gallbladder is impacted, again, the same thing, you can have empyema. And what is a mucocele? Mucocele is accumulation of mucus-like fluid in the gallbladder. It is not pus. Here you are get pus, but here is not pus, but it's very clear fluid like a mucus. It's a mucocele of gallbladder. Right. And what about Mirice syndrome? Mirice syndrome is where a gallbladder sits into the hepatic duct and cause obstruction of the hepatic duct. So if you want, you can, if you're interested, you can read about Biliary syndrome. It's a little bit of advanced knowledge. You can learn about Biliary syndrome. And if the gallstones erode, you can perforate into an adjoining structure. Most of the time, what are the adjoining structures to the gallbladder? Transverse colon, small bowel. So you can get gallstone ileus perforation resulting in gallstone ileus. Right. So what are the investigations that you are going to do if you get a patient in your emergency setup, in your when you are working in the ETC, Emergency Trauma Center, when you do your final clerkship with us, gallstone patient with biliary colic, cholecystitis can present to you, very common. So what are the investigations you are going to arrange as a house officer? So first thing, you will do a full blood count, definitely. So full blood count will be high in cholecystitis and in cholangitis, but not in biliary colic. What about the liver functions? The liver function tests are usually normal in straightforward biliary colic and cholecystitis, but sometimes they can be high, slightly elevated, especially if there is ascending cholangitis or Biliary syndrome. Liver functions may be abnormal. If the patient is septic and patient is very unwell, high fever and hypotensive, and you think patient is having septic shock, you must send blood for cultures. Take blood for cultures and send for gram stain culture and ABST. And if you're suspecting empyema, cholangitis, severe problems, you must do some blood culture. So now you will see this gallstone disease. It's a spectrum of problems. You can have very not that significant symptoms, like most of them 90% are asymptomatic, and from that end you can go into conditions like cholangitis with about 70% mortality. So it's a spectrum of problems that you can get, with minor abdominal pain to cholangitis, septic shock, and with high mortality. So then if you get amylase, if you do amylase, the amylase will be high, especially if you are suspecting acute pancreatitis due to stone obstructing the pancreatic duct. What are the further investigations that you are going to do? Ultrasound scan, yes, it's the diagnostic. When you see the patient, say typically a female in their 40s coming with right hypochondrial pain, fever 2-3 days, maybe second third episode you have missed and you have not done operation properly on after first episode, and they keep on coming, they lose their job, and nobody looking after their family, nobody look after children. So somebody had not properly done the surgery, and the house officers in other wards have missed their history. So a patient may have come to you third episode of right hypochondrial pain, and you do your take your history, examine, and you have a clinical diagnosis of acute cholecystitis, and then you, as a house officer, start your drips and keep the patient in orally, give something for the vomiting, for the pain. If you want, you need a catheter and relieve the pain. That's number one. And then you continue to do your investigations, and ultrasound scan is usually diagnostic. It will confirm your diagnosis of acute cholecystitis. So it demonstrates gallstones. There will be acoustic shadow within the gallbladder, and it's very characteristic. When you see patients with like this, you will go to the radiology department. The enthusiastic medical students and house officers will accompany this patient to the radiology department, and you will introduce this patient, present this patient summary to the radiologist, and the radiologist will teach you what are the features of ultrasonic features of acute cholecystitis. So these are the features: increased thickness in gallbladder wall, especially in recurrent disease, and if there are stones in the biliary tree, you will see dilated biliary tree. Abdominal X-ray, um, only in about 10% of the time only you will see gallstones as a radio opaque shadow in the X-ray. So abdominal X-ray of not much value. Other imaging, you can get erect chest X-ray to exclude any perforation, to rule out any other differential diagnosis. Because these patients will present with acute abdomen. So your other differential diagnosis will be your perforated duodenal ulcer, perforated bowel. So if you suspect any other differential diagnosis, you must take a erect chest X-rays to rule out any perforation, gas under the diaphragm. Sometimes other investigations like CT, magnetic resonance cholangiopancreatogram, ERCP will be helpful. How do we manage these patients? Right. So biliary colic, we have told you about 90% of them are asymptomatic, so you don't have to do anything there. Biliary colic, symptomatic. So biliary colic means they are symptomatic. So ask them to avoid fat, and usually we offer them surgery, especially if these patients are diabetic. It's known to be complicated disease. So therefore, if they come present with biliary colic, we offer them surgery. The surgery is laparoscopic cholecystectomy. And especially if they have diabetes, we offer them early surgery. So therefore, remember this. So don't just discharge them from the ward after this episode, and they will suffer with pain and they will have to come back to the hospital. So therefore, as a house officer, it's important for you to arrange a clinic visit for this patient. Usually I see these patients after 1 week. After 1 week of discharge, you see them in the clinic and plan out your surgery. So there are these historical medical treatments, medical oral dissolution therapy, which is poorly effective, and there is slow response and also high recurrence rate. So therefore, we don't practice those things at the moment. So cholecystitis. So the admission to acute ward, I have told you. So give IV fluids, analgesics, antibiotics, and keep them nil orally until the acute situation is sorted. Antiemetics, that's sort of management for the acute cholecystitis. If there's empyema, when you do the scan, and the radiologist will say there's empyema. Empyema is pus collection inside the gallbladder. So you will have to stabilize them with antibiotic fluids, stabilize their cardiovascular compromise, and offer them surgery. Percutaneous drainage, ultrasound guided drainage of that pus, or you can offer open or laparoscopic removal of the gallbladder, depending on your availability of the facilities and depending on your expertise, you can do. But if there's empyema, that pus inside the abdomen has to come out as quickly as possible. So therefore, best thing would be to do a percutaneous ultrasound guided drainage tube into that gallbladder. In cholangitis, cholangitis is when the patient is very, very severely unwell, very septic, and you will need to talk with the ICU consultants and get the patient into the ICU for monitoring. And also, if there's cholangitis, you will have to talk to the gastroenterologist to do a ERCP, and maybe you will have to arrange a stenting. Your consultant will arrange that, but as a house officer, you will have to do all the investigations and keep all the investigations ready when these patients needs referral to other specialties. Right. This is a algorithm where I tried to give you a summary of the management of a patient with biliary pain. Let's see whether we can follow this. So if they have inflammation, biliary pain, inflammation means cholecystitis, that you know already. No inflammation means biliary colic. So what are you going to do? Biliary colic, straightforward biliary colic, you give analgesics and you do your liver functions, ultrasounds, scan, and you confirm your presence of gallstones, right? And then you move on to, there's risk of cholelithiasis is low. Ultrasound will say no duct dilatation, gallstones in the gallbladder. That means you know the gallstones are only in the gallbladder, nowhere else in the ducts. So what you do there is risk of cholelithiasis is low. If the patient is unfit for general anesthetic, you conservatively manage with pain management. If the patient is fit, usually these patients are middle-aged people. They are usually fit for surgery. Their most common comorbidity is diabetes. So if they are fit, you do a pre-assessment, you assess the fitness for anesthesia, and you offer them laparoscopic cholecystectomy, right? On the other side, let's say there's inflammation. When there's inflammation, you know, with biliary pain and there's inflammation, that is cholecystitis, okay? And you treat that episode with antibiotics, everything what we have told you, need orally antibiotic, antiemetics, analgesics, right? And At the same time, you do liver functions ultrasound, you confirm gallstones, right? And acute cholecystitis, gallstones present in the scan, no gallstones in the ducts, choledocholitis. No risk, risk of choledocholitis is less. Same thing. You offer laparoscopic cholecystectomy. Unfit for general anesthetic, conservative. But if there is a risk of high risk of gallstones in the biliary tract, the ultrasound will say intra and extrahepatic duct dilatation, and then that means there can be a possibility of stone in the ducts. So you arrange ERCP and stenting, right? And when you do ERCP and stenting, the ducts will clear, and if the ducts clear, you offer surgery later on, right? That is the how you manage roughly a patient with biliary pain. Right. So what is the gold standard? Gold standard, not gold standard. GOLD standard, GLLE standard. Gold standard for biliary colic and cholecystitis. You do laparoscopic or open. Now that we don't do a lot of open surgery, but about 25 years ago, people did a lot of open surgeries. So now the gold standard is laparoscopic cholecystectomy. When you do this operation is very much debatable, and there are two schools of thought whether you do a hot cholecystectomy. What do you mean by the hot cholecystectomy? A hot cholecystectomy is where you do the laparoscopic cholecystectomy in the initial presentation. Say the patient has come, patient is still in the ward and resolving acute cholecystitis, and in that admission, without discharging the patient, in the same admission, say for example, after about 5 to 7 days of admission, without discharging, you take the gallbladder out. That's called hot cholecystectomy. So what are the advantages of hot cholecystectomy? You should be able to tell me. So this is the recurrent disease. So if you discharge them, they can come with another episode. Nobody knows when they will get the next episode. So therefore, hot cholecystectomy will avoid another admission with acute cholecystitis. That is hot cholecystectomy. So we do a few hot cholecystectomies, but most of the time we do interval cholecystectomy. What is the meaning of interval cholecystectomy? Interval cholecystectomy is where the patient completely resolves from the acute episode. They get better after about 5 to 7 days. They get better. All their blood results are coming back to normal. They are taking orally very well, tolerating, no vomiting, no pain. They are able to mobilize, and the house officer has managed this patient very well. So this patient is discharged from the hospital after the first episode, and they are usually, I review them in the clinic, and then you plan for an interval cholecystectomy, usually after about 6 to 8 weeks. After about 2 to 3 months, you do a interval cholecystectomy. So there is an advantage there. There are a couple of advantages in interval cholecystectomy, because you allow some time to resolve the inflammation, so that the operation is less bloody and relatively easy operation. But what is the disadvantage of interval cholecystectomy? Your patient is waiting for about 2 months for the operation. So during this waiting time, patient can have another episode of cholecystitis and come back. Then in that unit, they also plan interval cholecystectomy, so the operation gets delayed by further 2-3 months. So therefore, this becomes a vicious cycle where patient gets admitted with acute cholecystitis. So, and they are treated properly and they are discharged, and you wait until you wait for your lap chole, you will get another episode. So therefore, those are the disadvantages. But therefore, now the world is nowadays moving towards hot cholecystectomy, because it's a burden to the healthcare system. Patients get admitted repeatedly with the same problem. So in countries where people are very much concerned about health economics, they have done research and found out doing hot cholecystectomy in the first episode. That is how all these things have evolved. People, not like our country, people do research and find out how best to manage this patient. So, the health economics come into play. So what is the best method so that you can economically do these operations and manage this patient? So people have come out with this hot cholecystectomy, where the patient is operated on the same admission without discharging and without keeping them waiting for another operation. You do hot cholecystectomy, and once and for all in one admission, the trouble is over. So a lot of people, although and we did a lot of interval cholecystectomies, those now we try to because the world is also moving forward on that line. A lot of people, especially in the Western countries now, they do hot cholecystectomy. The problem in hot cholecystectomy is there is a lot of inflammation and a lot of bleeding, and there's edema around the tissues. So sometimes operation may be a little bit difficult, but now the world is moving a lot of towards hot cholecystectomy because of the patient compliance. They like it because their trouble is over in one admission, right? So what are the complications? Now you know the gallstones with the forming gallbladder, and they can migrate through the ducts and can go through the colon bile duct. They can go to the pancreatic duct. They can obstruct in the sphincter of body and cause a lot of complications. So let's see what are the complications of gallstones depending on the site. So complications depend on the site of stones. Say stones within the gallbladder. What are the problems that you can get? 90% asymptomatic. That is the number one answer that you should give. 90% of the gallstones are asymptomatic. And when they are in the gallbladder, you can get biliary colic. Now you should be able to tell me everything about biliary colic. Cholecystitis, mucocele, empyema, porcelain gallbladder. And very, very rarely, you can get gallbladder cancer, malignancy of the gallbladder wall. That's why all the gallbladders that we remove are sent for histology, and about less than 1% of them will come as cancer. So that is when the stones are in the gallbladder. When stones are outside gallbladder, you should be able to think about what happens. You can get obstructive jaundice. If they obstruct the ducts, common bile duct, you can get obstructive jaundice. If they obstruct the pancreatic duct and the sphincter of body, you can get pancreatitis. You can get cholangitis. Then you have a polycystic abscess. If the stones move out of the biliary tree and they can erode into the transverse colon or small bowel, you can get a cholecystoenteric fistula. Then you can have gallstone ileus, Mirisi syndrome. So what are the complications of cholecystectomy? That's also important to know. If it is laparoscopic, whether it is laparoscopic or whether it's open, you can get bleeding, infection, bile leak, bile duct injury. If you are not very familiar with the abnormal anatomy of the biliary tree, that is why you learn anatomy in the first and second years. And you damage any biliary duct, you can get bile leak. And some of these patients will have what is known as post-cholecystectomy syndrome. That is where patients' initial symptoms are not cured by that's about 10% of all patients undergoing cholecystectomy will come out with the same symptoms, right hypochondrial pain. But though it's there, it's very mild, but they will again say that their symptoms are not 100% resolved. So that's called post-cholecystectomy syndrome. So then if you do a laparoscopic operation, you can get port site hernias, because for lap chole we put about 4 ports, and these port sites can give rise to port site hernias. Right. So this is another chart which shows you advantages and disadvantages of the different surgical approaches. Now let's see. Laparoscopic approach, open approach. Have you all seen laparoscopic cholecystectomy? People, wake up from your sleep. Hello. Have you all seen lap choles? Hello. Have you seen laparoscopic cholecystectomy?
Yes, sir.
Yeah, very good. Have you seen open cholecystectomy? Not very much, no, because nowadays people don't do a lot of open cholecystectomies. But when you take consent for these patients for surgery, you must take consent for both operations, because at the time of surgery, if there's a difficulty, we may have to convert this operation into a laparoscopic procedure, so that patient is under anesthesia. So at that time, patient can't give consent. So it is your duty as a house officer to take consent for both procedures when you are taking consent for surgery. So let's see the two main methods: laparoscopic approach and open approach. This is in the middle. What is in the middle is a mini. I think we don't have to know a lot about this method. This is laparoscopy, open here with a mini incision, with a small incision. It's called small incision cholecystectomy, Sheffield technique. So people used to do cholecystectomy. It's again open method, but we'll consider these two. So what about laparoscopic method? Supervision is easy to supervise. It's easy for me to train a registrar to do a laparoscopic rather than open, because open, you will appreciate the last lecture, very difficult to see other than the surgeon and assistant. Others can't see that much. So therefore, I can easily supervise laparoscopic surgery when a junior person is doing, so I can see it on the screen. Training, yes. So training, again, when you supervise is good. When you can supervise them easily, you can train them well. You can train them because I can tell them, right, okay, do this, do that. This is your first step, second step, like that. You can train the juniors, you can train young surgeons to do this easily compared to open. Because open restricted view, only the surgeon and few others, only the close assistants will be able to see what's happening inside. So it's unstructured training. Conversion to open, like if you do 100 laparoscopic procedures, about 5 to 10% of laparoscopic cholecystectomies will get converted. So tell me, what are the reasons for conversion? What are the reasons for conversion of laparoscopic into open? Hi, hello.
Perforations.
Very good. Perforation of gallbladder, damage to the common bile duct. Anything else which you can't control laparoscopically? I told you last week.
Uncontrollable
Severe bleeding.
Very good. Bleeding inside where you can't control. You have damaged some vessel and there's a lot of bleeding where you can't stop that bleeding laparoscopically. You will have to convert. Anything else? I have told you at the beginning of this lecture. I have told you very, very important thing. I told you why. That is why you learn anatomy. That is why you learn from your lecturers in anatomy. I told you.
Abnormal anatomy.
Abnormal anatomy, brilliant, excellent, well done. Because if there's abnormal anatomy, you're not going to do with if you are unsure about anatomy, abnormal anatomy. If you suspect abnormal anatomy, about I think 10% of the population will be having abnormal anatomy. And if you have abnormal anatomy, you will not proceed with laparoscopic method. You will open and do it openly. Very important, because if you proceed and if you clip this common bile duct and divide that, that is the end of the patient. You will be having a lot of problems. So therefore, if you are not sure, always open. So is conversion of laparoscopic surgery to open surgery, is it a failure in surgery? I want this to go into your mind. Is it a failure in surgery? Conversion from laparoscopy to open surgery, is it a failure in surgery?
No, sir.
No, it's not a failure. It is the safety. Whatever the method you are going to do, you are offering the maximum safe procedure to the patient. Patient safety is number one, right? So this is why I always tell them, I like to have a patient, a living person with a scar in the abdomen rather than a dead body with 4 holes. Which one do you like? I'm sure you like the same thing. I don't like a dead body with 4 ports, but I like a living person with the central midline scar. So although laparoscopy is there, we should, as clinicians, we should select patients carefully. Although it is there, yes, it's very good, very advantageous to the patient, everything, but you have to select patients very carefully to the procedure. And also, even at the time of laparoscopy, the patient safety is number one. If you injure the bowel, if you injure the common bile duct, and you cause bile leaks and problems, there is no point doing laparoscopy. Then you do open. So conversion of laparoscopic surgery to open surgery, it's not a failure in surgery. So sometimes you will be asked these things in the Viva or maybe MCQ. You can say, yes, it's not a failure. It is the safe procedure. You do a operation for the maximum safety, right? So mortality in these two procedures are relatively the same, right? Infection rates relatively the same, less than 5, more than 5. Very infection is not ongoing. This post-op infection. Wound infection, let's say about wound infection in laparoscopy. What do you think wound infection in laparoscopic surgery compared to open surgery? Come on, talk. Hello. You can talk now. Wound infection in laparoscopic surgery compared to open surgery. Open laparoscopic cholecystectomy open. Yeah, in open wound infection is more. In laparoscopic, so you should know that, because there's small incisions and less contamination of the tissue, so therefore less wound infection, less than 5 and more than 5. DVT less in laparoscopy, more, again little bit more in open surgery, because they have pain and they will be immobilized for some time. But in laparoscopic surgery, lap chole, they can go home the next day. Most of the time we discharge them in about 2 days, 3 days. But in open surgery, they will stay in the ward for a good 1 week or so. Therefore, more chances of getting DVT in these patients. So hospital stay, I just told you, a laparoscopic cholecystectomy, you will do the surgery and you can do it as a day case operations. And sometimes in most of the developed countries, people come in the morning, they are fully prepared, pre-anesthetized and assessed as outpatient, and they are admitted to the day case unit on the same day morning, and operation is done during the daytime, and they are sent home on the same day evening. But for you to do these day case operations, you should have a lot of good backups. You should have telephone facilities, and they should have transportation facilities, so that any problem they can come back to the hospital very quickly. But in our setup, it's very difficult to do that. So therefore, but you should know that hospital stay in laparoscopy is very much few days, but in open surgery is quite long day. Right. Return to full activity. Yes, laparoscopy actually you can come back to normalcy earlier than this. I think this is a bit wrong. So usually these people, after about 2 weeks, they'll be fully much back in the action. But of course, in open surgery, it takes longer than that. Right? No scars can be seen. Nobody will know the operation is done in the abdomen. But of course, it's going open surgery. Incisional hernia rate with the small port size, very small, tiny port size, incisional hernia are very much uncommon. But it's very high in open surgery. All right, this is what I have mentioned in the beginning, and what you told me that you have learned in anatomy this much, right? Okay. Variations in bile duct anatomy. Now, this is actually very important to visualize. So this is the normal anatomy. You can see this is the normal anatomy. So you can see the gallbladder, the Hartmann pouch is here, and you have the cystic duct and joined by the common hepatic duct, right and left hepatic duct, common hepatic duct, and forms the common bile duct, and that goes and opens to the second part of the duodenum. Now, you should find out in the population how many people have the abnormal pattern. So you must refer your anatomy books and find out what is the population. I want to know that, because I don't know that. So therefore, you must next time you must tell me what is the percentage of people who are having abnormal biliary anatomy. Now these are the abnormal one abnormality, long cystic duct. But this is of course nothing to worry. Even if you get a long cystic duct, better for your laparoscopic surgery, because you have a long duct to clip. If you have this abnormality, you shouldn't be worried. Why? Because you have a long duct. There's plenty of area for you to clip and cut. But you will mistake this to this common bile duct. That's the problem. Here you are. This variation. See, now this is opening. Cystic duct is opening into the right hepatic duct. Now see, if you are not careful, you will do this. Clip, put 2 clips here and dissect here, disaster. There's no way that this part of the right part of the liver can drain its bile, problem. So this is an important anatomy, right? You will accidentally, without your knowledge, if you don't appreciate this abnormality, variation in anatomy, you will clip here and cut it, cut the right hepatic duct. Here you are again, the duct is coming behind. Now this is very dangerous because you will see the gallbladder. You might think this is the cystic duct, and you will clip and cut the common bile duct. Cystic duct is still there. Okay, so very important to appreciate the anatomy. Now here you are, another one. Without the Hartmann pouch and cystic duct, the gallbladder directly opens into the common bile duct. Again, dangerous because you have no space for you to put a clip here. You will open and do an open surgery, or you will do what is known as a subtotal cholecystectomy. You will remove the gallstones and all that and cut it here and suture and do a subtotal cholecystectomy. Another variation. Now see, you have a accessory duct of bile drainage, accessory duct of Luschka. This is called accessory duct of Luschka. Then anatomy is fairly normal, but then there's an accessory duct. So you will do a cholecystectomy, clip here, cut here, and when you dissect out the gallbladder from the biliary, from the liver bed, if you are not careful, you will just cut it and you will open it. You will open it, and what happens is this is draining from the liver, and it continue to drain, and there will be bile collection. There's a bile leak from the liver bed, and post-op there's a big bile collection here. So this is a accessory duct of Luschka, which you will have to clip it. If you see it, that is why you have to have a clear vision when you take off the gallbladder from the liver bed. Advantage of laparoscopic surgery is you can bring, I told you on the first lecture, your camera, the surgeon's eye to this area and have a very good vision, 6 times magnified vision of the biliary tree, of the liver bed. And if there's accessory duct of Luschka, you can see it. You will see a white structure and you will clip it and cut it, or you can tie it. Otherwise, if you miss that, there is a bile leak and there is a collection of bile and there is a problem. Right, here you are, another problem, another variation in bile anatomy. So gallbladder opens directly into the right hepatic duct, very dangerous, because here what happens is you will not appreciate laparoscopy. You might think this is you see the gallbladder and you'll be in a hurry and you saw another duct, you will clip this and cut it. What are you cutting? Right hepatic duct. So problem. So very important to appreciate the abnormal anatomy of the biliary tree. Right, now let's see. Oh my goodness, we have actually the time is up. What we'll do is now, I thought we'll be able to do 2 lectures, 2 topics in one go, but since the time has already run out, I'll keep the acute pancreatitis to another day, and we'll go on normal way, and I'll schedule the acute pancreatitis to another day. Are you all with me? Hello?
Yes, sir.
Yeah,
Yes,
okay. So now it's question time. What are the questions you have? Anything that is not clear to you? Anything that you want to clarify? You can ask your questions loud. Today is a very disappointing number of participants. I have seen only 140, which is not adequate. Now, last time we had about close to 200. So I want that number to appear next week. Otherwise, I'm not going to come here at 7 o'clock in the morning. I have my endoscopy list and do the ward round at 8. So you have to participate. If you don't participate, that means you are not interested. So we are not interested either. So I'm coming here not because I don't have any work. I have to now run the endoscopic thing, and I have to do the ward round, see all the post-ops from yesterday theater. So I want 195 plus tomorrow next time. If not, we are not going to do this. Okay. So there has to be some discipline. People, because I know because last time I had 195. So I know that those people are there. Now I want next week those people to be there. Otherwise, I'm going to inform the dean and the VC and say that people are not interested. Okay, I'm coming here. Do I have other work to do? So it is your duty to show your interest and come and participate and ask questions. Otherwise, I'm not going to do anymore. Right? Okay, question time. Those people who have not come, tell them to be there next time. I want 190 up. Okay, question time.
Sir, what are the advices included publications.
Ask them to avoid fat. Females, so they usually eat a lot of fat. So ask them to avoid fat. It is anyway good not only for not only for biliary problems. No, so avoid fat. Then if you have done laparoscopic surgery, okay, you have to take care of your wounds for about 1 week. Very important not to get the wounds wet. Usually we put absorbable stitches, so they will have to take. You have to give some pain management, little bit of, and then antibiotics for about 1 week. Following lab coli, I usually see them after 1 week in the clinic. So you have to fix an appointment with me in the clinic after 1 week. All these patients who undergo surgery, whether it is elective or emergency, we want to see them after 1 week. So we want to see how they are. We want to have an idea of our operation, how they are performing, how they are doing, whether they are in pain, whether they have a complications. So you have to fix an appointment with me after 1 week in the clinic. So during that time, until we see them in 1 week, you must tell them to take care of the wound. Advise them not to get the wounds wet. Right? Most of them ask you whether it's okay to bath. They can bath, but always you can ask them not to get the wound side wet. But now that there are these waterproof dressings that you can put there, even they can take a bath on top of the wounds. That's not a problem. Right. So other advice is, if they have any other problems, they can always come back to the emergency until we see them in the in first week. They can come to the emergency department if they have a big problem. But usually these people tolerate the operation very well. The other advices are that they need to have a look at the histology. It's very important though. So histology takes about good 2 months in this hospital. So you will have to review their histology, because very rarely these gallbladder removed gallbladders can come out to be malignant. So therefore, although it's very rare, it's important to review the histology. And also, when you review histology, you will know that they had chronic cholecystitis, and you can tell the patient the operation was successful, removed your gallbladder, so they should not get problems with gallstones hereafter. So those are the advices. But then, of course, if you have done open surgery, it's important to advise again, take care of the wound, and also not to participate in heavy strenuous work for about 2-3 months, because they can have incisional hernia later on. So those are the types of advices that you will give. Any other questions?
What is the place of cholecystogram? IV and oral cholecystogram?
We usually don't do this. Now this is very straightforward. Now these people have found out straightforward this problem, biliary colic, cholecystitis. We straight away, the management is this. We don't do too many investigations, because it's not cost effective, right? So you have seen that now the people are moving not away from interval cholecystectomy to hot cholecystectomy. So therefore, this management is straightforward, well established, and people do this without any problem. So we don't need, unless they are very much ill, we don't do any other investigations. So most of the patients who are coming with biliary colic cholecystitis will undergo hot or interval cholecystectomy, right? Okay, right. Okay, was it good, and were you able to understand?
Yes, sir.
Very good. I noticed only 2 people communicate. What about the others? Others having any problem with their, what happened to their vocal cords? I can see only 1 female and 1 male is responding. What about others? Can you tell me that you are there? 144 people. Are you there?
Yes, sir.
Yes, sir.
Yes, sir.
Others. I can hear only 2
Yes,
voices.
sir.
Others, can you say? Can you tell me whether
Yes,
I can't? I don't know whether you are there. Say that you are. I am there. Say I am there.
Sir, I'm
I
there.
am there.
There.
I am there,
I
sir.
am there.
And
I am
45
there,
I
sir.
am there, sir.
voices should be there. I am there. There.
I am there, sir.
Very good. Very good. Okay. So next time it should be 190 plus. Okay. Right.
Thank you, sir.
Okay.
Thank you,
Thank
sir.
you, sir.
Thank you, sir.
Thank
Okay.
you.